In light of recent developments regarding the presence of Ebola virus in U.S. soil, we have been working tirelessly in collaboration with local and national agencies, as well as experts in an effort to devise the safest and best approach based on our current resources. The training you're about to receive meets and exceeds the most current CDC recommendations and current Dallas County EMS standards. This training is the first step in ensuring the safety of our personnel and our community. In the weeks and months to come, we will continue to reevaluate these standards.
Okay, sir, help is on the way. Don't hang up. I still have some questions and instructions. Does he have any shortness of breath, or is he unable to take a deep breath? A little trouble breathing. Okay. Does he have a fever or a cough? You think he has a fever. Okay. Has he traveled outside the country in the last 21 days or been in contact with anyone that has? Okay, which country? Sierra Leone. Okay. Was this caused by an injury, or is he altered at all? No. Okay. Is he sweaty, clammy, or pale? No? Okay. Any nausea or vomiting? Okay, keep him on his left side. Do you know what may have caused this? No. Okay. Well, keep an eye on his breathing, and if anything changes, call back, but the units are on their way. Thank you, sir.
Engine 1LA, check your MDC for updated patient info.
Hey guys, this is a possible Ebola patient. Let's take precautions before we enter.
Ebola is a rare and deadly virus that is currently affecting several West African countries. The virus was first identified in 1976 and has resurfaced sporadically in areas of Africa. Recently, 43 people have come into contact with a man who became infected in West Africa and then traveled to the U.S. Of those 43 people, only 2 contracted the disease. These 2 were nurses that were repeatedly exposed to large amounts of body fluid during the time when he was most contagious. Nigeria was recently declared Ebola-free after initially confirming 20 total cases. This is important because it speaks to the scientific evidence of safely managing this virus even under heavily populated and developing circumstances. The countries currently affected by the outbreak are Guinea, Sierra Leone, and Liberia. These are the countries being referred to collectively as West Africa, and the countries being used during the screening process for possible Ebola patients. Once someone becomes infected with the virus, symptoms may appear between 2 and 21 days, but generally occur between 8 and 10 days. Early recognition and treatment is the key to increasing survival. The important thing to remember is that a person is not contagious until they start to show symptoms. Ebola has been shown to be present in all body fluids. To be clear, these include blood, saliva, mucus, vomit, feces, sweat, tears, breast milk, urine, and semen. The only way to become infected is by having the virus come into direct contact with your mucous membranes, breaks in the skin, or through a needle stick. Direct contact means that the body fluids where the virus lives of the infected person have touched someone else's mucous membranes or broken skin. Because the Ebola virus is found in all body fluids, current recommendations involve 3 levels of precaution: standard, contact, and droplet. Although sneezing and coughing are not common symptoms associated with Ebola, it is still possible to transmit the disease in this way. While fever is the primary sign of Ebola, other symptoms include severe headache, muscle pain, weakness, diarrhea, abdominal pain, unexplained bleeding or bruising. Because Ebola symptoms can be vague, emphasis is placed on the sign of fever. Patients that have just developed the symptoms are in the very early stages of the disease. These patients have a very low viral load and are therefore less likely to transmit the virus to others. As the disease progresses, the virus multiplies, making the patient sicker and more contagious. This was the stage in which the 2 nurses we discussed earlier were infected. It is anticipated that the majority of our potential Ebola cases will be in the early stages of the disease. If you become exposed to the virus, what's considered high risk? In other words, what kind of exposure would make it likely that you would contract the virus? These high-risk exposures include direct contact through broken skin or mucous membranes, or direct skin contact without the use of PPE. Lower risk exposures are things like living in the same house as the infected person, or coming into close contact with them. Close contact is defined as within 3 feet and not wearing any PPE. These circumstances would mean that even though you may have been exposed, it is highly unlikely that you would contract the virus. When you consider the possibility of contracting the virus through infected items or surfaces, it is important to know that the Ebola virus does not survive well outside the body. It can live on dry surfaces for only a few hours and in body fluids for several days. It is highly susceptible to standard hospital-grade disinfectants. These include bleach, Spirit 2 spray, Super Sanicloths, and alcohol-based sanitizers with an alcohol concentration of at least 70%. Because the virus lives in body fluids, and because these body fluids may interfere with the effectiveness of disinfectants and hand sanitizers, it is recommended that a person wash their hands with soap and water as soon as it is available to them. The currently warehouse-stocked department disinfectants that effectively kill the Ebola virus are Super Sanicloths and Spirit spray. It should be noted that the blue top alcohol wipes stocked in the warehouse do not meet the minimum alcohol concentration requirements of 70%. It is important to verify alcohol concentration on any hand sanitizer when using it to sanitize against Ebola. When considering disinfectants, it is also important to consider and abide by the recommended contact times to ensure that the disinfectant has enough time to kill the virus entirely. So what is considered a defined exposure after responding to a potential Ebola case? Anyone coming into direct unprotected contact with body fluids of a confirmed Ebola patient, or anyone coming into close contact with a confirmed Ebola patient. Close contact is defined as within 3 feet or within the same room for a prolonged period of time, with no PPE. If you meet either of these criteria and the patient is confirmed to be infected with Ebola, you are considered at risk for contracting the disease and will be quarantined for a period of 21 days while monitoring the signs and symptoms. Direct contact again would be considered high risk versus close contact being considered low risk. During the 21-day monitoring period, it is important to remember that exposed persons are not contagious until they start to show symptoms. Those that become infected with the Ebola virus and survive can no longer spread the virus. In some instances, the virus has been found in semen as long as 3 months from the time of recovery. So survivors are advised to abstain or use condoms for 3 months after recovery. Preventing exposures is the key. This is achievable through the use of PPE, proper infectious control, and early patient identification. When it comes to PPE, donning and doffing are the utmost importance. These processes need to be slow and meticulous in order to avoid exposures. The Ebola virus is detected in the blood only after the onset of symptoms, usually fever. It may take up to 3 days after the symptoms appear for the virus to reach detectable levels. In the case of confirmed laboratory diagnostic evidence, hospitals have to consult with the CDC directly in order to ensure that the patient meets their criteria for testing. All initial Ebola diagnostic testing is conducted locally by the Public Health Department, with confirmation performed by the CDC. While there is no specific medication, treatment, or vaccine for Ebola, treatment focuses on keeping the patient alive, giving fluids, and managing the serious health problems that can occur. As of October 27th, all travelers arriving from West Africa will be followed daily by state and local health departments. This new monitoring process will diminish the likelihood of our pre-hospital personnel coming into contact with a new unsuspected case. and also will ensure that the cases that we do come across will be in the very early stages of the disease. There are 4 main goals in the Ebola Preparedness Plan. Goal 1, provide our personnel with up-to-date information and training. Goal 2, early identification of high-risk patients. And 3, minimize personal exposure. And Goal 4, provide safe and compassionate care to our personnel and our patients. Goal 1, provide personnel with up-to-date information and training. This consists of the safety stand-down that you're participating in, the training videos, the hands-on PPE training, the preparedness job aids, and information updated regularly on the Internet portal. It is important to remember that this information is dynamic and may continue to change as more current guidelines and recommendations become available. Because of this, it is imperative that all department personnel check the Ebola Internet portal for the latest information as it applies to our department. The Internet portal will provide the fastest route of dissemination for the latest information coming in from national and local expert sources. Our current screening process includes all medical complaints. This means that the patient will be experiencing some form of medical symptomology. The fever is the prevailing sign denoted by the CDC. So therefore, if the caller says that they do have a fever and they have traveled within 21 days or have been in contact with someone who has traveled, the prevailing initial medical presentation becomes irrelevant. Because Ebola symptoms can be so vague, we are strongly relying on the sign of fever. Keep in mind that these screening questions are likely to change as the guidelines for the criteria shrink or expand. Make sure to check our portal regularly for the latest information. All callers with medical complaints will be screened for fever and travel within the last 21 days. Callers that meet the criteria will trigger immediate field notification in the form of an MDC pre-arrival message. Patients who meet this screening criteria will trigger an additional response. The Hazmat Task Force, 2 local battalion chiefs, the Health Hazmat Unit, a high-risk ambulance will all be included. Captains shall confirm with dispatch that these additional units have been added to their response. In addition, calls meeting the screening criteria will trigger a conference call, including the whole Ebola notification team listed above. There are 2 scenarios for personnel screened as high-risk patients. The first is by dispatch. If those are previously identified, all personnel will rescreen these patients for fever and travel to confirm. The second scenario involves our personnel identifying a high-risk Ebola patient upon their arrival. If so, withdraw immediately from the environment, don proper PPEs, notify dispatch, and ensure the response of additional high-risk resources. Goal number 3, to minimize personal exposure. This will be achieved through the use of PPE, both donning and doffing. The 2-person team approach also minimizes personal exposure by designating a minimal amount of personnel to engage in the overall care of the patient. Let's talk a little more about each one. The current department Ebola PPE standards meet and exceed the current CDC guidelines for PPE recommended in hospital cases dealing with confirmed Ebola patients. The CDC has emphasized that this level of PPE is really meant for healthcare providers that are caring for confirmed Ebola patients and who are likely to come in contact with large amounts of body fluids from these patients. Although hospital settings generally present a higher risk of transmission than pre-hospital settings, our dynamic environment presents unique challenges because of the uncontrolled nature of our work. We have to take these challenges into consideration and develop a department Ebola PPE standards opting for higher levels of protection. In considering these standards, we have also taken into account the use of elements that are readily available to all personnel, and for safety reasons, the use of elements that all personnel have been trained with and are familiar with. The basic principles of donning and wearing PPE are donning it correctly in the proper order before entry, and not attempting to modify the PPE once you've entered the patient's environment. The donning sequence must be directly observed by a trained observer, and this trained observer is responsible for ensuring that the donning process is conducted correctly through the use of a checklist. The CDC also recommends that this trained observer assist with the removal of certain PPE components, provide brief guidance and recovery if mistakes are made, and be readily available to intervene in case of an emergency. We will address all of these recommendations using a three-pronged approach that we will discuss shortly. Doffing, or taking off contaminated PPE, is a high-risk process. This requires a structured procedure, a trained observer, and a designated area for the removal to ensure protection. The scene captain shall function as the designated safety officer. It is his responsibility to maintain his supervisory role, set and maintain a safe pace, and provide step-by-step instructions to personnel using the donning and doffing safety checklist. It is also his responsibility to carefully observe each step and provide guidance for any necessary corrections. Suspected Ebola cases will be cared for through the use of a two-person department team. The first team member will be designated for operating in the close contact area. This team member will provide any necessary patient care. In order to minimize further exposures, this same team member will accompany the patient during transport in the ambulance. The second team member will maintain a safe distance, greater than 10 feet, and shall avoid coming into unnecessary contact with the patient's environment. The functions of the second team member will be to document and/or provide assistance with equipment, maintain scene safety and awareness, and provide any necessary support to team member number 1. Goal number 4 addresses these 3 areas. First, how we will provide patient care and transportation. Second, how we will ensure safety and infection control standards through the biohazard disposal and decontamination process. And third, how we as a department will care for our personnel in the event of an exposure. It is anticipated that the majority of suspected Ebola patients that we will encounter will be in the early stages of the disease process, and these will require minimal pre-hospital interventions. These initial interventions will involve BLS measures only until consultation with the base hospital occurs. During this consultation, the overall circumstances and the patient's condition will need to be evaluated and analyzed for risk versus benefit. This should be thoroughly documented in the PCR narrative and NFIRS. With all suspected cases of Ebola, we will be providing the patient with an N95 mask to minimize exposure. If the patient's condition contraindicates this, then a non-rebreather mask will be used with high-flow O2. All non-essential, non-wipeable equipment will be disposed of in the biohazard waste bag. Air transportation of the expected Ebola patient is not indicated and is discouraged due to the possibility of viral air dissemination in the aircraft. This poses a risk to all aircraft personnel. Additionally, due to industry safety standards, aircraft personnel may not be able to don all appropriate elements of the PPE. Ambulance providers have devised a plan by which to provide special ambulances outfitted to transport suspected Ebola patients. These ambulances should be activated early through dispatch to allow sufficient time for the response. All contaminated PPE and non-essential equipment coming into contact with the patient shall be treated as biohazardous waste. This waste needs to be double-bagged in leak-proof bags. Double-bagged biohazardous waste should be sent in the ambulance to the hospital. All biohazardous waste remaining on the scene or in the ambulance will be handled by the health hazmat crew. Every effort should be made to minimize equipment exposure. The recommended initial contact equipment should be the EMT box and a bottle of Spirit 2 spray. This equipment box shall remain closed until need is established to open the box. Once opened, every effort should be made to avoid contaminating the contents. Using the department two-man team, it is recommended that the safe zone team member maintain a safe distance from the patient along with the equipment in hand. The close contact team member can then walk to the safe zone team member for a safe handoff of the equipment necessary. Make every effort to avoid touching each other's gloves during this handoff. If this occurs, decontaminate the gloves with the sani cloths immediately. Any wipeable, non-porous equipment coming in contact with the patient or their environment needs to be decontaminated thoroughly by spraying it or wiping it down with Spirit 2 or sani cloths. Be sure to adhere to the recommended contact time of 10 minutes for Spirit 2, 3 minutes for the sani cloth. If the contents of the EMT box become contaminated, the non-wipeable porous contents shall be discarded in biohazardous waste bags and the wipeable contents thoroughly disinfected using the method and contact times described. To reiterate, the department's disinfectants that will be used on Ebola are Spirit 2 spray with a contact time of 10 minutes and sani cloth with a contact time of 3 minutes. Reminder: do not use the blue top Sanidex alcohol wipes. These do not meet the minimum recommendations for alcohol concentration. The department is also in the process of procuring a substitute that meets this new 70% standard. In the meantime, personnel are to purchase personal containers of hand sanitizers that meet the 70% concentration criteria. Potentially exposed personnel will be immediately placed out of service with move-up coverage provided for all affected units. Command and Control will make notifications to initiate a conference call with all decision makers to discuss the next steps. Test results will be provided within 24 to 72 hours depending on the circumstances. Most incidents will be ruled out or resolved within the first few hours. If the patient is deemed to not have met the criteria for testing or the test results are negative, then all personnel will be returned to full duty. If the patient meets the criteria for testing and the results are positive, then all personnel exposed will be put on administrative leave and provided the option of a quarantined residence with the appropriate follow-up care. These personnel will be transported to a predetermined housing facility for quarantined care and monitored for 21 days from the time of exposure. If these personnel show any signs or symptoms, they will be immediately transported to a predetermined specialty care center. Once the 21-day period has passed, with no symptoms reported, the personnel will be released from quarantine and returned to full duty.
Andy Trujillo with American Medical Response. Behind me, you see one of our ambulances has been outfitted to transport high-risk patients, as well as our employees who have been training with specialized isolation kits. In the event of a high-risk patient, you can call us and we can send you one of these units with our staff members.